and I'm डॉक्टर बुलाओ इधर. Good evening, everyone. I'm Dr. Sumedha Verma, resident of Diabetology, AED Hospital. I welcome you all on the behalf of AED Hospital for this CME program. The chief guest of honor for today is Dr. Madan Mohan Garu. He is the president of Branch Kukatpalli IMA. Sir, please come on the dais. Welcome, sir. Can I have a bouquet for Dr. Madan Mohan Garu? Sir is senior most clinicians and with the experience of over 37 years of experience. He is the IMA president of Kukatpalli branch, Hyderabad, Central Working Committee member, IMA Telangana State, EC member of API Hyderabad chapter, EC member in RSSDI, Telangana State, and this is his second term, professor in TRRIMS Medical College Medicine Department, currently practicing medicine in Sri Rama Clinic KPHB. On behalf of Dr. Ravi Mupedi, sir, I am welcoming you, sir. Please initiate the inaugural session of today. Thank you.
Thank you, Dr. Sumedha. On behalf of IMA Kukatpalli, welcome all our esteemed members, and I would like to welcome our guest lecture speakers, Dr. Elizabeth Moses. Yeah, am I right? Yeah, and Dr. James. Okay, sir. Hello, sir. Dr. James Jariya and Dr. Ujma Khan. So, welcome all this to the Kukatpalli branch, and this is a very good gathering. Today's gathering is I'm seeing a very almost new faces also. So, for further introduction, I would like to hand her mic to Dr. Sumedha Verma. She will give the detailed guest. She will introduce the guests for the today's session. Thank you, please.
Thank you, sir. It's an honor to have you on this CME meet. We are going to highlight few things today. To begin with, AED Hospital is the first endocrine treatment and research center in Kukatpalli, Hyderabad. It was started in April 2010 by qualified endocrinologists with a vision to enhance quality of life in patients of hormonal disorders, the motto being changing lives. The main specialty, thyroid care, diabetes, obesity, hormonal lab, to name a few, diabetes, eye care, menopause clinic, CGMS and hormonal pharmacy. I take the privilege to speak more about these things, but after the first session, I would like Dr. Uzma Khan to come onto the stage, please. She is the first speaker for today's CME. Dr. Uzma Khan, please, may I have a loud round of applause for her? She is a consultant endocrinologist, AED Hospital, MD Medicine, MRCP, UK, MSc Endocrinology from University of South Wales. Specialized in diabetes and endocrinology from Royal College of Physicians. Presently, she is speaking on the topic lifestyle modification, back to basics. This topic basically will highlight a known fact, acknowledged by most, addressed by few, ignored by all of us. It's back to basic, lifestyle modifications. Please welcome Dr. Uzma Khan for this next session.
Thank you, Dr. Sumedha. Just need to look at my slides. Are they there? Thank you, Dr. Sumedha, for the kind introduction. Good evening, everyone. Am I audible at the back? Am I audible at the back? Yeah? Yeah. So I welcome you all to this session on obesity, medical and surgical treatments. As we know, obesity has risen to pandemic proportions, and it's a major public health issue, and it's a call for action, and we all are in this together. So on this note, I would start my talk on lifestyle modifications in the management of obesity. There are no actual or potential conflicts of interest in relation to this presentation. Is it better? So my objectives for today's talk are: discuss the principles of effective lifestyle intervention, appreciate the challenges related to weight loss and weight maintenance, and describe some evidence-based strategies to help achieve weight loss goals. So obesity can be conceptualized as a consequence of positive energy balance and physical manifestation of chronic energy excess. If we look into the concept of energy in and energy out, and the cause of weight gain, more energy in, that is overeating, and less energy out, that is undermoving, we advise people to eat less and move more. But unfortunately, that does not work, and we will see why. So for the behaviors, overeating and undermoving, there are various drivers which we need to look into. So the environment we are currently living in is highly obesogenic. We have easy access to calorie-dense, high-energy food, and our lifestyles have become sedentary. The socio-cultural factors also impact our eating behavior and physical activity habits. And our biology, so our genetics, medical comorbidities, and issues like hyperphagia or medication related to medical illnesses, all that affect our eating behavior and physical activity. And psychology, again, plays an important role. So some emotional eating or comfort eating, eating disorders, then psychiatric issues, psychiatric medication, all that can affect our eating behavior and physical activity as well. So it's very important, and I can't emphasize enough, that we need to assess for root causes of weight gain. So apart from increased intake and reduced activity, the third component is slow metabolism. So we need to look into all these. I'm not going to go into the details of all this, but would just touch upon a few. So for slow metabolism, if someone with advanced age would have a slower metabolism compared to someone young. Genetics also affects our metabolic rate. Neuroendocrine factors like hypothyroidism, Cushing's syndrome, growth hormone deficiency, hypogonadism, that can slow the metabolic rate. And something like muscle loss due to recent illness, sarcopenia, also slows the metabolism. And after weight loss, so if someone loses about 5 to 10% of the weight, their metabolism might slow down by up to 20%. So that is a significant fall, and we need to be aware of that. Then coming to the increased intake, as I said earlier, it's socio-cultural factors, physical hunger, emotional eating, psychiatric disorders, etc. Then reduced activity could be just due to physical limitations, medical comorbidities, musculoskeletal pain, or psychiatric disorders again. So we need to address the root causes before moving on to planning further management. So this is the algorithm for obesity management from the ACC, AHA, and Obesity Society guidelines. And if you look at the right, once the person is ready for the intervention, the first thing which is advised is comprehensive lifestyle intervention. It can be given alone or with adjunctive therapies, which is pharmacotherapy and surgical treatment. So this slide is just to highlight that this is the first step, and this is the backbone of obesity management. So after we have evaluated for causes of weight gain and set like a person is ready, then we set the weight loss goals. And the evidence from randomized controlled trial says that it is quite reasonable to aim for a 10% weight loss over 6 months. So this is found to be effective and safe. But weight maintenance, after the initial weight loss, we always come across this situation when they regain the weight. So weight maintenance is a real issue. And once someone loses weight, the metabolism slows down, as I have mentioned earlier, and the hunger increases. So the ghrelin hormone increases after weight loss, and there is reduced satiety. So there is reduction in leptin, insulin levels, and peptide YY. So all that, so the body is trying to get back to the baseline weight. So the body is against the weight loss. So it's very important that in this phase, the diet is continued, but physical activity plays a very important role, and that needs to be more intensified. And behavioral therapy is really important to facilitate diet and physical activity behavior. And all these three must be continued indefinitely to maintain the weight. And that is true for pharmacotherapy and surgical therapy. So after surgical therapy or pharmacotherapy, this thing needs to be continued indefinitely. So if we look into what an evidence-based intensive lifestyle intervention is, there are counseling sessions. So for intensive intervention, they advise about at least 14 sessions spread over 6 months, and it could be in-person, web-based, or commercial. And this usually leads to 5 to 10% weight loss. The moderate intensity would be somewhere around 10 sessions spread over 6 months, leading to 3 to 5% weight loss. Then diet, usually they have tested the moderately hypocaloric diet in the intensive lifestyle intervention studies, and for women it is somewhere between 1,200 to 1,500 kilocalories per day. For men, 1,500 to 1,800 kilocalories per day. And macronutrient is as per patient preference. So we don't have data in favor of any specific macronutrient like low carbohydrate, high protein, low fat. So as long as calorie restriction is maintained, the evidence says that it would lead to weight loss. And exercise in the initial phases, in the weight loss phase, it is at least 150 minutes of aerobic exercise, so moderate intensity per week, or more than that if possible. Then behavioral therapy is also advised during these interventions. So the person should be monitoring their diet and activity. It could be a journal, a diary, or it could be a mobile app. And weekly monitoring of weight is very important, so they should have a weighing scale. And structured curriculum of behavioral change implemented by an interventionist from the weight management team. And regular feedback and support should be provided to the patients during intensive lifestyle intervention. And if we look into the randomized controlled trials, the first trial which comes to our mind, it was a landmark trial called Diabetes Prevention Program. So it was done in obese, overweight, pre-diabetic patients in 27 US centers between 1996 and 2001, more than 3,000 participants, and there were 3 arms: intensive lifestyle intervention, metformin, and placebo. And the intensive lifestyle intervention group aimed for a 7% weight loss, and they followed similar sort of things. So there were about 14 sessions and calorie restriction, behavioral therapy. So everything was there as we discussed in the last slide, and the results were quite significant. So after 3 years, they found that the intensive lifestyle intervention, there was a reduction in diabetes incidence by 58%. Metformin, it was there, but less than the intensive lifestyle intervention group. And if you look into the first graph, we can see that the most weight loss was with the lifestyle modification compared to metformin and placebo. The second trial I would like to mention about, it's also a landmark trial after which people have started to talk about diabetes remission and meal replacements. So this one was the direct trial. Included obese, overweight, type 2 diabetics, but early onset. So diabetes duration was less than 6 years. 49 UK primary healthcare centers. So it was done in the GP practices under supervision from the principal site, and 300 participants, and all of them, they stopped their diabetes medication before going into the trial, and these people were prescribed, so the treatment group was prescribed very low calorie diet. It was between 825 to 850 kilocalories per day for 3 to 5 months, with gradual food reintroduction over the next 2 to 8 weeks. And then these people received advice for maintenance therapy over a total duration of 2 years. So if someone was going back to the previous weight, or they were deviating, they again received some very low calorie diet for a few weeks just to get back to the baseline. So the results were quite impressive. After 1 year, almost half of the treatment group were in diabetes remission, and weight loss as high as 15 kilogram was seen in 1/4 of the participants in the treatment group. After 2 years also, so just maintenance phase, so it wasn't very low calorie diet at that time, so just maintaining a balanced diet, and being monitored, the remission rate was still like 1/3 of the participants were in remission. They were not on any diabetes medication. And one thing, the important thing which came up was the higher the weight loss, the higher the chances of diabetes remission. So people who lost 10 kilogram of weight loss, they had a remission rate of 64%. So that's quite significant there. Then coming to another study, Look Ahead study. It was a cardiovascular outcome study for intensive lifestyle intervention done in type 2 diabetics, overweight, obese. I'm not going into the details, but the result was that after 10 years, there was a sustained weight loss of about 6% in the intensive lifestyle group compared to the standard diabetes support education group, where it was 3.5%. And when we look into the graph, we see that the weight, physical fitness, waist circumference, and HbA1c, all of that was much better in the intensive lifestyle intervention group. But unfortunately, there wasn't any cardiovascular benefit. So both the groups had very low event rate actually. But what they found that with intensive lifestyle intervention, there was improvement in metabolic markers, like there was improvement in glycemia, lipid profile, liver fat, then reduction in the diabetes medication. So it was quite a significant thing, and it was a strong message for our patients. We can say that even if they don't lose a lot of weight, then also there is metabolic health benefits which can be achieved with lifestyle intervention. So summing up the intensive lifestyle intervention studies, it shows that calorie restriction does lead to weight loss. So there is RCT evidence for this. Then meal replacements are a good option to introduce calorie restriction. And higher the intensity of lifestyle intervention, more is the weight loss. And metabolic benefits are not solely dependent on weight loss, as we saw in the Look Ahead study. And there are other studies as well. I have not included all of them, but we have RCT evidence for all these. Moving on to dietary management. So the key here is that we need to decrease consumption of energy, and a hypocaloric diet needs to be prescribed in the initial phases. So we have moderately hypocaloric diet, which was used in the trials, 12 to 1500 for females, 15 to 1800 for males, and is generally well tolerated and facilitates adherence. Then the highly hypocaloric diet, it's less than 800 kilocalorie per day. It could be between 4 to 800. But it has to be done under close medical supervision, and we don't have safety data beyond 3 to 5 months. So that is the thing, but moderately hypocaloric can be prescribed by most of the physicians, but then again they need all those inputs from the dietitians or the behavioral therapists, team member from the weight management team. And the other thing is just to be aware that if we create a calorie deficit of 500 to 1000 kilocalorie per day, that leads to approximately 0.5 to 1 kilogram weight loss over a week. So this graph and this study just illustrates that adherence to calorie-restricted diet is more important than the type of diet. So there was this study where they compared Atkins, Zone, Weight Watchers, and Ornish diet, and the weight loss was pretty similar, but when they followed these people up for over 1 year, they found that for all those diets, people who adhered to treatment, they had more weight loss. This is just a compilation of RCT evidence for a few dietary interventions. So we have supportive evidence for low-calorie diet, very low-calorie diet, meal replacements, DASH diet with energy restriction, Mediterranean diet with energy restriction, and then decreased sugar, sweetened beverages as well, low-carb diet with energy restriction that would be, but we don't have RCT evidence for the other diets. Moving on to physical activity. So it's integral part of obesity management. It has got modest effects on weight loss, but important benefits to preserve fat-free mass during the initial phase of weight loss. And it also promotes weight maintenance, as I have mentioned earlier. So initial phase, when they're losing weight, it is 150 minutes per week at least. But when they are trying to maintain the lower weight, they have to increase the amount of exercise, and it would at least be 200 to 300 minutes per week. And some studies have said as high as 60 minutes per day. So that's quite high, so it's quite difficult to maintain that lost weight. So we have to emphasize that they need to continue everything, and exercise plays a much important role in the maintenance phase. And the exercise should be tailored to patient's ability and health status. Then coming on to behavioral management. This is just stages of behavioral change. This is just to show that when we are seeing patients in our clinic, they may not be ready for whatever we are advising them. So the initial 3 stages in blue, they are when they have not started to act. And the first stage of pre-contemplation is when they have some concerns, fears, they don't want to lose weight. And in this phase, we just have to explore and try to find out the reasons and not suggest anything at that time, just to listen. And in contemplation phase, they are thinking about it, they have mixed feelings. Here is when we reinforce the benefits of weight loss and the risks of obesity. The preparation phase is when they are ready to act, and we negotiate the objectives and plan with them. I'll discuss the objectives in the next slide. But after this, they go into the action phase when they start to act and start the diet physical activity part. But this is not the end, this is beginning. Because they may do it for a few weeks or few months. We all have seen that. So few weeks, few months, and then they would stop. So we have to search for obstacles and be supportive. Then in maintenance phase also we need to reinforce the benefits, look into the obstacles, give them some problem solving skills. And with that also they would relapse or go into a plateau phase. Then it's just encouragement, normalizing the situation, saying to them that it's quite common to go back and it happens all the time. Just try to learn from your mistakes and get going, get back on track. So it's just supporting them throughout these behavioral change stages. And coming to the objectives, so when they start to act, at that time, we discuss objectives with them, and this is something which is useful to prescribe, like SMART objectives. So it should be a specific goal. We say to them 10% weight loss, so 10 kilogram. Then it should be measurable. So they should have a weighing scale to measure because it should be structured. We can't give vague advice. Then it should be achievable. So someone who has lots of comorbidities, we can't set a goal of 10%. So we go a bit lower, give like 5%. Then it should be relevant. So they should really relate to that weight loss. They should be program in 6 months. We can divide that into smaller goals. So we can say 4 kilogram in the next 2 months. We see you and then keep monitoring your weight at home and try to be on track. So that actually, if they are going back, they would again try to intensify their thing. So it should be more structured and specific. So using this sort of thing can help. Then 80-20 lifestyle is just an example. So it's more of like a recommendation which leads to more adherence. So if we say to them that 80% of the time you can behave in a controlled way, so diet, exercise, controlled, but 20% of the time you can have less control. So on weekends, holidays, so this is more realistic because no one can be 100% perfect. And when we start, if they are very off the baseline, we can suggest that they start with something like 60-40 and then intensify it further to 70-30 and then 80-20. So it's just a behavioral approach to facilitate adherence. And then before I finish, just want to touch on something called language matters. So there is a huge global drive to adopt a person-first language in some chronic diseases. Like for diabetes, they don't want to be called diabetics. So they don't want to be called by their disease. So people with diabetes, person living with diabetes. So similarly for obesity, we should be avoiding stigmatizing and blaming terms like fat, morbidly obese or chubby, and try to use more neutral terms like overweight or high BMI, unhealthy weight. And coming to the conclusion, I can't emphasize enough that lifestyle modification is the mainstay of obesity management. It does not lead to a lot of weight loss, so it would be about 4%. But this is something which is required lifelong. So even if they are on medical treatment or after surgery, they need to follow this. And long-term adherence is crucial. And behavioral modification is quite important because if that doesn't happen, it won't be lifelong. So to stick to something, we need to change the behavior, overall approach to their health. So with that, I would finish. And thank you for your attention.
Thank you, Dr. Uzma, for the excellent presentation, especially enlightening on the SMART goals and adhering to the basics for long-term objectives. Now I would like you all to please put your hands together for the next guest of honor, Dr. Satyanarayan. He is the President of ELEC. Please welcome on the stage, sir, and receive the honor. I would like you to come on the stage and speak few lines. Thank you, sir.
Doctor? James, not eligible. On topic?
So you take the bouquet, I will write down. Put your hands together, audience. Thank you.
So good evening everybody. At the outset, I congratulate Dr. Ravi Muppidi of Advanced Endocrine Hospital for arranging such a nice CME, which is the need of the hour because the lifestyle diseases are becoming very common nowadays. So addressing these problems, these type of CMEs are really needed to educate the medical fraternity and bring the awareness. So now I request, I invite the next speaker, James Jacria, to speak on surgical interventions on the management of obesity, right? Dr. Jacria James.
Welcome, Dr. James Zakaria. He has come long way from Dubai. Thank you, sir. It's an honor to have you for today's CME meet. Dr. James, a few lines on Dr. James Zakaria. It's a privilege to speak for his experience, long experience, though he has many feathers in his crown. Being a fellow trained certified in outstanding bariatric surgery, he is trained under the world leaders, bariatric surgeons from Taiwan. He is also fellow of American College of Surgeons and has several fellowships and internships of International Surgeon Society. He has helped several patients in losing weight through bariatric surgery, is expert in hidden scar approach that leaves no visible scar in the bariatric surgery through abdomen. He has over 30 years of experience. He has published several publications, research publications, like High Impact International Bariatric Surgery Journals. He presently practices in Dubai and was head of surgery department, Zulekha Hospital. On behalf of Dr. Ravi Muppidi, sir, I would like him to speak on the esteemed expertise topic on the types of surgery, including sleeve gastrectomy, colon surgery, laparoscopic hernia surgery, and not to ignore, he is also his tenure is more than 30 years. Fellowship in bariatric and metabolic surgery, was awarded the Outstanding International Bariatric Fellow in 2015. Please welcome. He endeavors in practicing evidence-based surgical care that results the best patient experience and outcomes. Put your hands together again. Thank you. Audience, you are really cooperative and loving. Thank you so much for your cooperation.
Thank you, Dr. Sumedha. Good evening, everybody. I know it is quite late, and thank you for your patience to listen to academic lectures at this time of the day. Maybe many of you have come from clinics, and I hope what we present will be of some use. And please bear with me as I put on these slides together. You may wonder why I landed up here. Dr. Ravi is a very close friend. So I was visiting him and he said, okay, we will have this talk which will help our people. So that's how I landed up here. First of all, let me bring greetings to you from Dubai. Yeah. So I'll start with this slide first. Conclusions. Okay. Conclusion of my talk is that metabolic syndrome, which is also called as ABCD, I'll come to that later, is a global pandemic resulting in colossal medical expenditure and one of the leading causes of non-communicable deaths, as you would have already understood before. Indians have a form of adiposity that exposes them to metabolic diseases at a lower BMI compared to the Western population. Metabolic surgery, which I'll define later, is now providing a substantial solution for the treatment of obesity, type 2 diabetes, and other derangements of metabolic syndrome. Now, global guidelines support and recommend that metabolic surgery is good in the treatment of uncontrolled diabetes and in patients with BMI above 30, but for Asians, the cutoff is 27.5. We'll look into these. So this is basically what I'm trying to say today, and please bear with me as I deliberate through these. So my predictions, these are personally my predictions, just to provoke your thoughts. I believe by the year 2025, there are going to be many more people who are going to ask for metabolic surgery instead of going for medical management in diabetes. So that's maybe actually contradicting my previous speaker, Dr. Uzma, and of course, I hope Dr. Ravi won't be offended because of his practice. Everybody will come and say, we want metabolic surgery. Insurance companies, I'm not sure how much it is here available, but insurance companies also will start finding out that getting a patient early before they go through all the expenses of their metabolic syndrome, various endocrine problems, it's better that they have this preventive measure of control their weight management. So maybe insurance companies also can push or opt for metabolic surgery in the future. And I believe that soon we may have this metabolic surgery available as a daycare surgery in the future, maybe an endoscopic procedure or something like that. So with these things, things may change in 3 years. I'm not sure. This is just my prediction. You all know that obesity is actually a ticking bomb, not only in the Western countries. I'll come to show you that also in our own country, that is India, we are having this. It's going up. Thanks to our the culture of between this, between the 90s and early 20s, there is a lot of globalization of fast food, and that's how that peak has come. And now it's going beyond control. And they believe by the time it becomes 20, 30, and all that, you will have no difference. Most of the countries all over the world will have the almost similar kind of pandemic as we had this corona pandemic. So the prevalence of obesity in India, it's more common with people who are, as we heard, more of aged above 40. And among the rich, those who are a high income group, the highest income group, the levels are between 36 and 38. An important thing that I want to highlight today is that somehow people who measure obesity will always find that of this kind of a graph, which I want to show you. They think that the obesity in India is between around 8 to 10% or 8 to 13%. Whereas if you look at the if you look at people with BMI about 25, the real value is here. Okay. We have, as I told you, we have a special kind of obesity, the abdominal obesity, that even with a lower BMI, we are having metabolic disease. So if patients are having waist circumference of more than 90 centimeters, they are manifesting diseases like an obese person in the West. So one study shows that if we have patients, let's say if out of 100 patients who are having abdominal obesity, their regular obesity as per the WHO definition, which is BMI above 30, we will be able to get only 20% of 20 of them will be having obesity obvious. Even though they have abdominal obesity, only 20%. And here, among women, there's a little higher, that's 30%. So this discrepancy is very important. What I'm trying to say is that just BMI alone will not help us detect their risk for metabolic disease. And for Indians, we should have separate guidelines. And sure enough, our people have not been sitting idle. They have found out, and there have been a lot of deliberations. And 2009, more than 100 medical experts representing reputed medical institutions, hospitals, government-funded research institutions, they have said that guidelines is if anybody is above 25 BMI, they are obese in Indian standards. Just keep that in mind. I'm not sure if you have if you've seen these figures. A recent study, as recent as 2021, this is a study done in India. They found out that this obesity is 40.3% in overall India, and in especially South India, it's about 46.5%. Initially, I did not believe it because it is too high. It's almost as high as the West. But these people use this 25 BMI as their cutoff point as per the guidelines. So, if you look at the distribution like this, I just put this map for you to understand the overall incidence is 40.3. This is, you can check this, Venkat Rao et al. Annals of Neurosciences. You can check that on the net. You'll find this 2021 study where you find South India, we are having the maximum, 46.5%. So Hyderabad comes under that. 2017, the American Association of Clinical Endocrinologists and American College of Endocrinology positional statement was, we should now rename this as adiposity-based chronic diseases and not obesity-related disorders. It is adiposity because many of them have the adiposity-related illnesses. So that way, it clarifies and also focuses the attention on the adipose tissue. Dr. Usma has already elaborated a lot about the pathology and the lifestyle modification and all those things. So I won't be going into that. My talk would be more on the surgical aspects. As you know, diabetes is the major cause of all these things that you see here, whether it is gangrene, whether it's stroke, whether it is heart attack, retinopathy, amputations, end-stage renal diseases. So the true picture of diabetes is not just a figure on that screen there, but it is actually end-organ damage. You have strokes, blindness, heart attacks, and renal failures, amputations. This is what we are dealing with. In fact, I was telling that the fact that from being a general surgeon, I was trained to be a general surgeon long time back, but because I have been involved with cutting away limbs and dressings and necrotizing fasciitis, this whole thing about diabetes has been a great burden. Like, when you see a patient with diabetes, whatever you do is going to have trouble. You operate them, the wounds won't heal. So when I came to know about the surgical management of diabetes, I was interested. That's the basis of my interest in this field. Now, this is a study or an estimate done by the IDF about how much money is spent on the consequences of these different illnesses. It's almost, this is 1.3 trillion US dollars are spent on, we don't see obesity as but that is what is happening. We have cardiac intervention, stroke, dialysis. If you look at all the treatment given for all these things, they all come from adiposity-based chronic diseases. So it is an important public health issue. And this is just a slide to give you a perspective where if you could save even half of that amount, our entire Indian population can be insured. This is just a rough estimate that I made. So what is metabolic syndrome? So this is a quote from Henry IV. He says, if I have more flesh, because I have more flesh, I am very frail. It looks contradictory, but it is true. People who have more flesh, they are frail. And the basis is this metabolic syndrome. Quickly, this is the IDF definition of metabolic syndrome. I think all of you probably would have seen it, where it talks about abdominal obesity, type 2 diabetes, HDL, raised HDL, triglyceride, and hypertension. All these things can cause a lot of havoc in the body. The clinical components are like this. The disease part, it's not about just weight. It's about all these things happening in a patient, which is quite devastating. You see, you have obstructive sleep apnea, hypertension, PCOS, that is polycystic ovarian syndrome, dyslipidemia, and non-alcoholic steatosis, and type 2 diabetes mellitus. So imagine different specialists trying to treat the same patient. The cause is the same, disorder of the metabolism. So if you look at this patient, let's call him John. If John is 149 kilos, okay, and his problems are obesity, type 2 diabetes, hypertension, dyslipidemia, left ventricular hypertrophy, obstructive sleep apnea, NASH, and even psychosexual derangements because of obesity, how do you handle him? You can give lifestyle, you can give medication, but you find you have to treat all of them simultaneously. So a lot of I think money, time, and multiple consultations, a lot of things are involved with this. But what today we have seen is John can become like this in just 6 months or 8 months and enjoy his life, his family. everything together, and no amount of our treatments can give, medical treatment can restore John in this manner. He may be improving a little bit, but to give him such dramatic results is what I'm trying to share with you. So this person becomes this person after metabolic surgery. So that's why the interest is. So some treated patients. So this is typical patient we have operated while I was a fellow in Taiwan. Just to give an example, what happens when we do bariatrics or metabolic surgery. A typical case, 109 or 110 kilos, body and BMI was around 40, triglycerides and LDL was like this. The same person becomes like this. Sorry. So you find here his weight is 71, his triglycerides and LDL have come down, his body weight has, BMI has come down 26, waist circumference. All these things happen in roughly about 12 to 18 months after surgery. So these are some of my patients. A business executive who lost 40 kilos in 6 months and is off antihypertensives, no cholesterol lowering drugs, and no snoring, no daytime sleepiness and all that. This is a German nurse who lost 36 kilos in 6 months, no backache, no knee pain. She was finding it difficult to even do her regular duty because of her weight. No snoring and so on and so on. This is just examples of how people are transformed after a bariatric surgery. These are all patients who have operated before and after surgeries. So what is metabolic surgery? The person I am standing with is Professor Scopinaro. If you look at Scopinaro, he's a father of metabolic surgery. Okay, he started using surgical treatment, that is changing of the GI tract arrangements to have this end result of cure of diabetes or reduce all these risky metabolic parameters. So the definition is this. It's treatment of metabolic derangements with alteration of gut anatomy. This definition is given by this ASMBS, which is American Society of Metabolic and Bariatric Surgery, where I want to emphasize metabolic surgery, what we are treating is the metabolic syndrome, whereas bariatric surgery, we are treating for the overweight or obesity. So bariatric surgery means surgery for reducing weight. Metabolic surgery is to treat the metabolic derangements, which I think in the coming days, it's very essential for Indian population as we are slowly becoming the diabetic capital in the world. So the stress is not on weight loss, but on correction of the metabolic derangement. So how did this evolve? How did this metabolic surgery come? Nobody suddenly got up one day and said, this is metabolic surgery. It came an accumulation of experience. You would have known that when we studied in surgery, it is Theodore Billroth who actually first did the gastrectomy for cancer. Gastrectomies were done, partial gastrectomies were done for cancer and for peptic ulcer those days. So when they saw those patients, it resulted in weight loss after their operation, in addition to the cancer treatment and in addition to the peptic ulcer. So they thought, why not we use those operations for treating weight issues. But then when they initially started treating, 1960s, they found many of their weight loss attempts had plenty of complications like diarrhea, severe malnutrition, and even mortality was very high because they did not know how to do the surgery. They would anastomose something to something like stomach to ileum or jejunum to ileum, jejunal-ileal bypass or to colon. There were so many experiments that were done, and there was so much of severe complication that it went into bad reputation. So people did not do in the 1950s and 60s. But afterwards, they saw how to overcome these complications. They started understanding the physiology of the operation better. And then when they got good results with weight loss, they found out that in addition to weight loss following these surgeries, there is a bonus effect of cure or treatment, good remission of diabetes. That was a surprise finding. So this is how the first article came up. William Porres, who put this, said, who would have thought of it? An operation proves to be the most effective therapy for adult onset diabetes mellitus. And this discovery, actually, they consider that is one of the greatest discoveries after the discovery of insulin. So what we see here is people who have had bariatric surgery, almost 80 to 98 in some cases, they have complete remission from diabetes. So it is interesting. So this is just a real time, this is one of our patients from Taiwan during our fellowship. So this is just an example how the sugars are at that level between 400 and 500. During that time, the insulin requirement was 72. In spite of that, the levels were so high. The operation was done here. It's actually a metabolic operation called DJB, that is duodenojejunal bypass, so it's sleeve gastrectomy, a higher end operation. But as you see, by the time they come from 11th May to 18th May, how the graph has come down in few days. Even though there is no weight loss, the sugar metabolism has actually changed so much that there is a recovery and there is a less requirement of even insulin. And many of them, as you go on further, if you look at this long term, HbA1c at the time of operation must have been around 9, but at the end of 9 to 12 months, it comes down to around 6. And this is a typical case, or even less than 6, 5.8, 5.9, without any medications. Of course, results vary because of different reasons, which I'll tell you later. So now I'm not going to go through much details regarding how this happens, because it will take a lot of time, and I want to actually hurry up because of the delay. But quickly, if I want to say, it is divided into what happens. As we heard about, caloric restriction is very important because the stomach pouch is smaller, you can't eat more. Improved sensitivity because of the changes in the intestine. So there's improved insulin secretion, improved insulin sensitivity, and decreased inflammation in the adipose tissue. So there is a whole lot of endocrine connection between gut, pancreas, brain, adipose tissue, muscle, liver. It's a very complex relationship. I don't think anybody has got it clear, but many people have put it into simplified ways so that we think, okay, this is how it works. But anyway, this is a complex mechanism. It also includes certain things like, how the food particles, is it partly digested, undigested food in the ileum can stimulate L cells, neuroendocrine cells, create more GLP-1 release. And there are also theories which say about gut microbes are different in patients who are regular patients and patients who had bariatric operation. If you look at the gut microbe, do you know that gut microbes are more than the number of cells in your body? This is just it. Okay, so that they influence a lot of our metabolism, the gut microbes. So the bariatric surgery also changes the composition of the gut microbes which exist in our body. And also the circulation of, you must have heard about enterohepatic circulation, circulation of bile acids, bile salts in the body. Even that is affected after bariatric surgery. These are the few proposed explanations for this effect, why sugar is controlled even in the few days after bariatric surgery. Even though weight loss is a long-term, it does not happen like, patients at 110 kilo does not become 70 kilo in few days. It takes about 1 year. But sugar levels come down within few days. This is about how adipose tissues inflammation comes down and how bariatric surgery actually decreases the macrophages number and adipocyte size, and also T helper cells. There is a change in the composition. The type 2 cells, T helper type 2 becomes more in number. So these are the changes that take place. It is not only just operating here. The whole body is reflecting the result of what we are changing here. That is why we call it as metabolic surgery. I'll quickly go through these slides. Already we have seen that decrease in the weight. There is bonus effects of how blood pressure is controlled. Surgical treated patients compared medical treated patients. How hyperlipidemia is controlled. Triglyceride levels come down. VLDL cholesterol comes down with bypass. With good, substantial difference between intensity. In fact, I'll come to that point where we are comparing intensive lifestyle treatment versus bariatric surgery later on. So compared to that, we are having good results with bariatric surgery. Even fatty liver, those who have gone through fibrosis, they reverse back very much. So the injury and the changes in the pathology, changes in histopathology is seen. And it happens in good number of almost 84%, and some here it says 15 out of 16 patients. Obstructive sleep apnea. There's a good improvement in obstructive sleep apnea here. Almost 75% saw an improvement in their obstructive sleep apnea, and they can sleep more peacefully. Pardon me for quickly going through in lack of time, but these are all the studies. There are plenty of studies actually. Polycystic ovarian syndrome, people who are unable to bear children because of infertility due to polycystic ovarian syndrome, after bariatric surgery, after 1 year, 2 years, they start actually having higher incidence of pregnancy. So in some cases, even the menstrual period is regularized. So how does it affect our mortality rates? Yes, it affects drastically. In fact, there's 50%, almost nearly 50% reduction in the mortality compared to control patients. Patients who are operated, their longevity and their lifestyle actually keeps them alive and adds years to their life. As I say, it adds years to their life and life to their years also. So this is to summarize. Many of you may be thinking, what do you do in bariatric surgery? So I hope this simplified diagram will clarify those doubts. I'll try to follow this. I'll try to explain the best way I can. So what are the anatomic rearrangements that we make normally? There are plenty of them, more than at least 30, 35 operations now being done. The common ones are there, the uncommon ones are there. So I'll put some of them here. This is typically how, let's say this is the schematic diagram. Esophagus, stomach, this jejunum, ileum, colon. Okay, that's normal. So in this operation called sleeve gastrectomy, everything is okay. Only this part of stomach we change, make this bag into one kind of a tube. That is sleeve gastrectomy. This is Roux-en-Y gastric bypass. Here, the change is again here. A little complicated operation. Stomach is divided this way. The blue part is redundant, whereas this small pouch is connected to what we call as a Roux limb or elementary limb. It connects down the biliopancreatic limb. That's why like a Y connection. Okay, so there is a biliopancreatic limb and there is a Roux limb and the common channel. Everything else is normal. That is Roux-en-Y gastric bypass. This is mini gastric bypass, where same like this, but instead of 2 anastomosis, there's only single anastomosis. So it is also called as one anastomosis gastric bypass. So here the stomach is reduced in size like this, divided. The blue part is left redundant. It does not get used. But the thin tube is connected to the intestine roughly around 2 meters down, 200 centimeters. I keep changing depending upon what results we want. Either make it less, let's 180 centimeters, or make it more, 250 centimeters. So that's a more of a calculation that we surgeons do on the table for certain reasons. This is sleeve gastrectomy with a sleeve gastrectomy like this. But in addition to that, we do a anastomosis also. So it's called sleeve gastrectomy plus duodenojejunal bypass. So this is sleeve gastrectomy done, plus instead of jejunal bypass is attached to the ileum. SADI, it's called SADI. It's a very high, I would say, bypass with a lot of side effects because we are going right down to the ileum to anastomose the stomach. So though we have so many operations, these three are the common operations that are done around the world. Okay, sleeve is the most common. Then comes the Roux-en-Y. Now mini gastric bypass is coming up more and more common in many places. So the range of different operations, I don't want to go through it, but just to let you know. So you may find these names. In fact, Hyderabad, I know there are people who are doing a lot of these operations. It's quite a good center of these operations. So you may be wondering, endoscopic, you must have heard about endoscopic bariatric therapies. Again, I don't want to go to the details. Balloons, constricting the stomach by endoscopic stitching. There's also one ridiculous method, I would say, where they make a gastrostomy and they make the patient eat and then they open the tap, and it's called aspirate assist. In fact, it is even FDA approved. But I don't know, this is how people are desperate to lose weight. They want to eat the food and also lose the weight. So that's it. So this is coming up slowly, where endoscopic sleeve gastroplasty is now coming up even recently. It has also been FDA approved for regular use. And there was this endoscopic duodenojejunal barrier lining. It's like something like a lining that prevents the food from touching this part of the C loop of duodenum and the upper part of jejunum. Somehow they found out that if you bypass that, you are having good metabolic effect, good control of diabetes. So it's called the DJB liner. But now they are not doing it, though it's an endoscopy procedure, because this has some complications like, prone for more hepatic situation, hepatic abscesses and all that. So I know I've confused you with so many things, but let me put some simple principles in your mind. So what are we doing is, we are attacking at 3 places. Bariatric surgery, common technical points of all metabolic surgeries. Number 1, the stomach part, where we are restricting the stomach. Okay, so first is the restriction, gastric component, restricting the stomach. The second is the jejunal or duodenojejunal component, where we are trying to bypass it. So stomach restriction, we are bypassing the duodenojejunal in some operations. And finally, ileal stimulation. When you stimulate the ileum, you provide those L cells to produce more of GLP-1 release. So that is, if undigested nutrients, they go to ileum by short circuiting, you can get, which is also known as the distal gut hypothesis. Whereas the duodenojejunal bypass is based upon the proximal gut hypothesis. Just keep that in mind. Well, this gentleman standing by the side of me is Dr. Michel Gagnier. He is the one who actually publicized his findings after sleeve gastrectomies, which is very commonly done. I was privileged to meet him in Korea. We'll play this video at the end, another few more slides, and then I'll play this video about how the sleeve gastrectomy is done. So I just want to also share with you something in the same line. I told you there are many operations. One is the food passes through a normal
sleeve procedure.
No. Stop. Food passes through the same channel like stomach, duodenum. Then in other operations, it does not pass through the same channel, it bypasses. Is there a difference between sleeve gastrectomy and sleeve gastrectomy with bypass? This was the study that we did during my fellowship. It was published. I was the first author. I'm so glad to share with you. What we compared was, there were many patients out of which we could shortlist with their matched BMI, so that there are no other variables, between 2 groups of people. One who underwent sleeve gastrectomy, other who underwent sleeve gastrectomy plus bypass, if I can put it that way. The difference I'll put you. So this is this. So let me show you the results first. So this is how the glucose tolerance curve. We gave them a particular meal, standardized meal for all the patients, and did this glucose tolerance test like how we do. So before surgery, all of them had a wave like this. So the food was given here, so it goes up, and I'm sitting in the middle of so many endocrinologists. They are very familiar with this curve. This is how a diabetic will respond in his blood levels of sugar. So after sleeve gastrectomy, this is how the graph comes up. It comes up sharp up, but it comes down pretty fast compared to the previous tolerance curve. But after bypass, you get even more lowering of postprandial sugars. So the spikes are very sharp and short, not long. This is one trial I will share with you quickly. It's called the Stampede trial, which means surgical treatment and medications potentially eradicate diabetes effectively. This is not exactly a comparison to say that the surgeons are doing better job than physicians. It is about showing how surgeons and endocrinologists can combine and give better results. This is what the thing is. So what they did was, this is done in Cleveland Clinic, USA. So they had 150 patients. So these 150 patients, they divide into 3. One is the first group, 50 medical therapy only and intensive lifestyle. Second, they did a type of bypass, Roux-en-Y gastric bypass. And third, they did sleeve gastrectomy. So these 3, 50, 50, 50, 150. So when they saw 3-year outcome, they saw this. In the medical therapy, about 5% we could achieve HbA1c less than 6% in the medical therapy. And but somehow this at the end of 3 years, what we had at 5% becomes 2% because of gradual, deterioration. Because all these are actually chronic disorders. They start increasing by the years. Comparatively, when you look at those who had a bypass, compare the figures. 5% 3-year outcome, less than 6% HbA1c. But here we have 38% less than 6% HbA1c. And after 5 years, even these also are not as impressive as the initial one. This is a sleeve gastrectomy, or 24%. So as I told you, bypass is more effective in controlling diabetes than the sleeve gastrectomy. This is called the Stampede trial. So which shows just by giving them medical treatment, we are not getting the best results that we can give the patients. Patients deserve this kind of, results, not this kind of results only. This is my advocation. So, Stampede trial, just a picture of the same thing about how the BMI comes down after the surgery. This is the medical therapy group. Medical therapy's BMI comes like that, whereas after surgery, you see how the BMI comes down. At the end of 1 year, they're almost coming to near normal levels. This is the HbA1c medical therapy, and this is a line we call the HbA1c is 6%, which is the line, cutoff line, where we say a patient is cured or not, or needs treatment or not. Sorry. So after bariatric surgery, you have, there are 2 lines here, one line indicating of sleeve gastrectomy, other line indicating of the bypass. So you see there's so much of difference between medical therapy and bariatric surgery. Okay, this is regarding the, I don't have time to explain this, but I'll just tell you a little bit. Patients who are having treatment for diabetes, they are having sometimes only lifestyle modification, some monotherapy, 2 therapy, or 3 medications, or all of them plus insulin. So if you look at it, this is how the pattern was before surgery, before intervention of medical therapy, and the difference is, see, not much of a difference. You see, a little difference is there, but still, they are still taking all those medications. When you come to the surgical part, after gastric bypass, you see what we had in this dark green. There were, instead of 2 people, now see, 45 people are without medications, 45%. And here, after sleeve gastrectomy, 25% are without medications. No medications, and they are treated completely from diabetes. Now, there are many studies comparing lifestyle modification or intensive medical therapy and bariatric surgery. Only one I shared with you, that is Stampede trial. But there are all these trials, almost 15 randomized controlled trials. And I'm not a statistician, but those who know statistics, that, the odds ratio, all the studies, all of them are above 1, which shows, in short, that this surgical treatment favors, surgical treatment is always superior to just medical treatment alone. That's my point. So this is the World Congress in 2015. Look at this graph. These red seats are all not surgeons. They're all endocrinologists. Okay? They met in London. And all these green people are internal medicine specialists. And then we have surgeons, about 25%. This green here. Sorry. This 25% is this one. And internal medicine 7%, cardiologist 2%. So in this combined gathering, we find that, they came up with this consensus that patients who are obese can be classified as class 1, that is 30 to 35, class 2, 35 to 40, class 3 is more than 40. So those who are even class 1, if their control is not good, they can be considered for metabolic surgery. This is you can go through this paper. It gives clearly today, so eligibility would be anybody above 40 BMI, Western standards, but Asian standards 37.5 should have bariatric surgery or metabolic surgery, irrespective of comorbidities. Anybody who's above 35 West standard or 32.5 our Indian standard should have metabolic surgery if they have diabetes. So what to do about people who are about around 30 BMI and still have diabetes? According to our Indian standards, we should also offer them bariatric surgery. In fact, till 27.5 BMI, they are eligible. I mean, if they are about 27.5 BMI and if they have uncontrolled diabetes, they should be offered metabolic surgery. How much time I have? I'll try to quickly. There is a prediction score which I am not going to share today, but there is a prediction where this is actually invented by my mentor, Professor Lee, who took the age, BMI, C-peptide levels, and the duration of diabetes disease and made a score like this. So, if a patient is having, let's say, let's consider a patient who's above 40. BMI above 35 and 40, and C-peptide 2, 2.9 and 4.8, we add it up. So above 40 is 0, 0 plus 2 plus 1, 3, 3 plus 1, 4. So let's say we come up with a score of 4. We call it ABCD score of this particular patient is 4. And then we put on this graph, those who are having 4, we can give them a prediction of almost 80 to 90% of remission. So the remission can be a complete remission, partial remission, or just improvement. Complete remission is less than 6 HbA1c and no medications. That is complete remission. But if it is with medication, we say it is partial remission. So I have come to this conclusion, same thing. What I want to say is that it is a global pandemic. Metabolic syndrome is a global pandemic and is causing colossal expenses in the medical system. Patients are spending a lot of money because they could not treat the root cause. And in India, we have adiposities, which is abdominal adiposities that exposes us to the metabolic risks. So metabolic surgery is a treatment and guidelines are supporting it, and that's the end of my talk. Thank you. This is a transformation we get through metabolic surgery. Sorry for the hurry up because I think I've taken time. If you want, I can show you that just for the conclusion, just for your eyes, the video of how sleeve gastrectomy is done. It will be a very short video, 3 minutes. So don't worry.
Let's get started. The gastric sleeve procedure is performed laparoscopically, which is a surgical technique where only small incisions are made. The laparoscope is inserted through a small incision in the abdominal wall. The camera sends images to a video monitor, which allows your surgeon to see inside your body without having to make large incisions. Laparoscopic surgery is a low-risk, minimally invasive technique with many benefits, including smaller surgical scars, less pain, shorter hospital stay, faster recovery, and reduced risks of infection. During the gastric sleeve procedure, we remove a portion of the stomach, leaving a small sleeve or tube of stomach behind. This small tube or sleeve of stomach is about the size and shape of a narrow banana. The gastric sleeve procedure works in two ways. One is that when you eat, the small sleeve or pouch of stomach that's left behind fills with each bite of food. Filling of that part of the stomach sends signals to the brain, and your brain thinks you have eaten a larger portion of food than you actually have. As a result, you feel satisfied and comfortable with smaller portions of food. The second reason the gastric sleeve is so effective for sustained weight loss is that it removes the part of the stomach that produces a hormone called ghrelin. Ghrelin is a hormone that makes you feel hungry faster between meals. by removing the ghrelin, you can go longer in between meals, which is a second and unique way to help control your portions. Studies have shown that, on average, a patient who has the gastric sleeve procedure will lose up to 70% of their excess weight, and that most of the weight loss will occur in the first year. For the majority of patients, the weight that is lost stays off.
Yes. 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 Yes.
Thank you, everyone. Now I want to invite our next CME event speaker. But before that, success is the sum of small efforts repeated day in and day out. This best describes our next speaker, Dr. Elizabeth Moses. And for her, I would like to invite Dr. Raghunandan. Please put your hands together for him. He is the president of IMA North Branch. Please welcome, sir, and grace the occasion and give the bouquet to the speaker, sir. Thank you so much. Thank you so much. Once more, I would request everyone to clap hands for him. Thank you, sir, for coming. Dr. Elizabeth, the speaker for next.
Good evening, everybody. I appreciate Dr. Ravi Muppidi for conducting the CME on obesity, which is a very burning topic, burning issue in our society. Now I call on Dr. Elizabeth Moses to talk on pharmacotherapy. I thank Dr. Madan Mohan and Ravi Muppidi. Okay, thank you. Please.
Good evening, everybody. Tonight I'll be discussing about the pharmacotherapy for diabetes. If you look into the disease burden, approximately 1 billion people worldwide will be affected with obesity by the year 2025. Unfortunately, obesity remains vastly undertreated. Only 2% of obese individuals receive appropriate pharmacotherapy for obesity, whereas as high as 86% of patients with diabetes receive pharmacotherapy for diabetes. As per the Endocrine Society Clinical Practice Guidelines 2015, it has advised to start pharmacotherapy in individuals with a BMI of more than or equal to 30 or a BMI of more than or equal to 27 associated with at least one comorbid medical condition such as hypertension, dyslipidemia, diabetes, or obstructive sleep apnea. The important point to be noted here is that they have advised for a long-term pharmacotherapy for obesity and not just in the initial phases of treatment. In this slide, there are a list of drugs approved by FDA or EMA for obesity. Drugs approved for obesity here are Orlistat, phentermine, topiramate combination, bupropion and naltrexone combination, liraglutide, semaglutide, and setmelanotide. In addition, on the right-hand side of the slide, there are medications which help in weight loss in patients with diabetes, but are not approved by FDA or EMA for obesity alone. They are metformin, topiramate, bupropion, naltrexone, GLP-1 analog, and SGLT2 inhibitors. If we look into the mechanism of action, except for Orlistat, the rest of the drugs target appetite mechanism. They target the arcuate nucleus situated in the hypothalamus, which stimulates the POMC neurons and promotes satiety. A quick look into this slide. We have the FDA-approved drugs which are semaglutide, liraglutide, naltrexone and bupropion combination, phentermine and topiramate, and orlistat. Tonight I'll be discussing about the drugs that are available in India, that is orlistat and GLP-1 analog. Orlistat actually inhibits gastric and pancreatic lipase and leads to reduced absorption of 30% of the ingested fat. It leads to approximately 3% of the total body weight loss. Orlistat was approved by FDA in the year 1999 and by EMA in 1998. Orlistat can be started at a lowest dose of 60 mg once daily to improve tolerability, and then a maintenance dose of 120 mg thrice daily. It's usually taken with a fat-containing meal. Since it leads to decreased absorption of other fat-soluble vitamins, it's important to provide multivitamin along with orlistat. Orlistat is contraindication in pregnancy, breastfeeding, chronic liver disease, malabsorption, and should be cautiously used when co-administered with drugs like warfarin and antiepileptics. Next, liraglutide. It's a GLP-1 analog. Initially, it was approved at a lower dose of 1.8 mg for treatment of diabetes. Subsequently, it was approved for treatment of obesity at a higher dose of 3 mg daily once. Liraglutide leads to approximately a 7 to 8% in the total fat loss. It was approved by FDA in 2014 and EMA in 2015. Liraglutide is given as a daily subcutaneous injection. Initially started at a lower dose of 0.6 and gradually over the weeks it is stepped up to improve tolerability of side effects. And then the dosing starts at 1.2, 1.8, 2.4 and 3. Liraglutide mainly acts on the brain, the stomach and the pancreas. In the brain it increases satiety and decreases appetite. On the stomach it decreases gastric motility, delays gastric empty and increases acid secretion. Whereas on the pancreas it increases the insulin synthesis, increases insulin biosynthesis, increases beta cell proliferation and survival, and decreases glucagon. The common side effects seen with liraglutide are usually gastrointestinal, which is nausea, vomiting, diarrhea and constipation, rarely fatigue and occasionally rash. Liraglutide is contraindicated in gallbladder diseases, pancreatitis, in patient with history of medullary thyroid carcinoma, and men too. Looking into the obesity treatment algorithm, once we start anti-obesity medications, after a month we reassess them for any side effects or any early weight changes. Suppose if the weight loss after 3 months is more than 10% of the weight, then we continue the same medications, and when the patient's weight hits a plateau, we plan to add a newer drug. If the weight loss is between 5 to 10%, then we continue the same ongoing anti-obesity medication, increase the dose if the side effects are well tolerated, and after 3 months again we reassess and plan to add a newer drug. But if the weight loss is less than 5%, we stop the current medication, restart a newer drug, and repeat assessing for each new drug. Here we have a slide that shows this patient taking orlistat and liraglutide at AED hospital. Approximately 1/3 of patients have lost weight with orlistat, whereas liraglutide, the 2/3 of patients have lost weight. So here it's indicating that liraglutide is more effective here. Now we have some meal replacements to provide energy restriction in management of obesity. We have some options like ProHands, Reshape, which introduce calorie restriction via meal or snack replacement. So our take-home message tonight will be: treat obesity as important as other chronic disease. There is a wide patient-to-patient variability depending on the treatment. One individual may respond to one anti-obesity medication and may not respond to other, and vice versa. Our goal at the end of the treatment should be that each patient should receive a suitable and effective anti-obesity medication. Thank you.
I would request the audience to note down their respected queries in the notepad provided to be addressed during the panel discussion in the later sections of the event. Thank you. Now, I would request Dr. P.V. Ratnakar, sir, the renowned pediatrician of Hyderabad, to come onto the stage and receive the bouquet. Dr. Raghunandan, Dr. P.V. Ratnakar, sir. I'm sorry, there's a little... Good evening. There's a slight change in the process. Dr. C.V. Ranganangan, the senior surgeon and ex-president, please welcome on the stage, and I would request him to come and grace... Yes, senior surgeon. Thank you so much. A round of applause from the doctors. I know doctors are the integral part of the society. Without them, the society is not happy and healthy. Would like him to come on the stage and please speak some few words on today's session. What are your thoughts, sir?
Is there any more speaker?
Dr. Rajita.
Okay. I thank Ravi for organizing a fantastic session today. And as is common, half the audience was following what is happening on this side. Half the audience is busy in their own activity. So on the whole, I say it's a successful meet. And in fact, this is the largest crowd in recent times when so many doctors came. Thank you, sir, for organizing a beautiful...
Speaker Dr. Rajita.
Okay, I call upon the last speaker, and I hope she'll make it short and sweet. Dr. Rajita.
Good evening, everyone. Tonight I'm going to talk about diversity, the twin pandemics. Diversity is an emerging concept. The term was actually coined during experiments on Israeli rats. They were actually fed with very high fat diet, which resulted in obesity and subsequently diabetes. And thus, a strong association between obesity and diabetes is already established, as we already all of us know. Talking about the disease burden, more and more every day it is becoming a major public health issue. It is projected that in next 40 years, the adults with obesity will increase by 6-fold. And it is also projected that the number of type 2 diabetics will increase to 642 million by 2040. So that is a major public health issue we need to concentrate on and focus. This is a timeline map that was made by CDC USA, which is representing a parallel increase in obesity and diabetes from 1994 to 2015. As we can see, obesity has increased from 14% to 26%, and diabetes from 4.5 to 9% respectively. And this is the diabetes linkage we are talking about. Extreme obesity results in diabetes because of insulin resistance, hyposecretion, and hyperglycemia. There is also additional beta cell dysfunction and destruction that is happening. So for every 1 kg increase in body weight, there is a 4.5 increase in risk of type 2 diabetes mellitus. Next, looking into the molecular mechanisms behind diabetes, there are There are about 3 hypotheses being proposed. The first one is the inflammation hypothesis. The next is lipid overflow hypothesis. And the last one is adipokine hypothesis. Talking about each of them, inflammation hypothesis basically explains about inflammatory molecules being released in a large quantities from macrophages which have infiltrated the adipose tissue. So these molecules bring about dysfunction of peripheral tissues as well as insulin producing beta cells, which ultimately results in diabetes. Next we are talking about lipid overflow hypothesis. This proposes that obesity causes ectopic lipid fat stores because these individuals don't have enough amount of capacity for the adipose tissues to store the fat, and these ectopic lipid stores produce a lot of dysfunctional endocrine factors, resulting in metabolic impairment of insulin sensitive tissues as well as beta cells of the pancreas. And the last one is the adipokine hypothesis, which proposes the white adipose tissue to be an endocrine organ and secreting a large number of dysfunctional endocrine factors, thus resulting in insulin resistance and impairment of insulin producing beta cells. So all the three theories are actually propounding almost the same one, being insulin resistance and destruction of the insulin producing beta cells. Next, looking at the genetic susceptibility. Genetics play a very important role in almost all of the metabolic diseases. So as single nuclear polymorphisms have failed to explain the linkage between obesity and diabetes and the genetic and the individual susceptibility, right now we have GWAS, which explains the gene-wide association studies, which have explained well about individual susceptibility genes, and more chronic the classical familial linkage analysis with wide genomic association studies are becoming more promising in explaining this procedure. This is a picture that is showing umpteen number of genes which have been implicated in obesity. So the central one is the FTO, which is the most promising, implicating, and promising one and the implicated one. Next, talking about diabetes. Diabetes is a complex therapeutic challenge. Diabetes and obesity result in metabolic syndrome or syndrome X, which is basically characterized by clustering of CVD, cardiovascular disease risk factors. Therefore, identifying a young diabetic individual and preventing obesity, early detection and treatment is very important to prevent this metabolic syndrome coming into the picture. Then shifting to the management of diabetes. Effects of diabetic medication on weight. This is something very, very crucial. Whenever we are treating a patient, an obese patient with diabetes, it is very important to prescribe the right medication, because if taking into effect the weight of each of these medications on the diabetic medications on the weight, as we can see from this slide, metformin and alpha glucosidase inhibitors are actually weight neutral or even cause modest weight loss, and DPP-4 inhibitors are supposed to be weight neutral. Then talking about sulfonylureas, meglitinides, thiazolidinediones and insulin cause weight gain, whereas the last two, GLP-1 receptor agonists and SGLT2 inhibitors, cause weight loss. So more and more the international organizations are proposing that GLP-1 receptor agonists and SGLT2 inhibitors be used as add-on therapies to metformin because of their significant weight loss effect. In addition, they are also cardioprotective, and SGLT2 inhibitors are also renoprotective in patients with established CVD. Next, we are going to talk about a few randomized control trials which try to explain the concept of diabetes and the effect of medication on the obesity. So the first one is the ADOPT study, which compared metformin with glyburide and lorziglitazone, and it proved that metformin actually causes a modest weight loss which persisted for up to 5 years, and that was a significant finding that was found, and it is therefore metformin is actually proposed to be the most safest, cheapest and effective drug of all the anti-diabetic medications. In this next slide, we are talking about SCALE trial, which was one of the RCTs which compared liraglutide with placebo. Liraglutide, it was found that with increasing dosage from 1.8 mg to 3 mg, there was increasing weight loss, and reduction in the A1C was also significant when compared with placebo. Next, talking about the effect of SGLT2 inhibitors on weight loss in type 2 diabetic patients. So this is basically a meta-analysis of most of the randomized control trials that were conducted on SGLT2 inhibitors. So this graph is representing that SGLT2 inhibitors caused about 3 to 4 kgs of weight loss in the first year of prescription itself, and that is inconsistent with the clinical findings. So the weight loss by SGLT2 inhibitors is basically caused by about 70 to 100 grams of glycosuria that happens because of their inhibition of their SGLT2 receptor in the proximal tubule of the kidney, which transformed to about 300 to 400 kilocalories of energy deficit, which in turn resulted in weight loss, and that was a significant weight loss that was found in there. The last one is the Duration 8 study, which compared GLP-1 receptor agonist and SGLT2 inhibitor individual effect with their combination effect on the weight loss, and it was found that the combination effect was more over and above the additive effect of each of the individual components of these drugs, and therefore combining these drugs for patients who need weight loss in diabetic patients is highly recommended right now. And the last one, diabesity, the role of bariatric surgery in diabesity is very huge, as I said, already been discussed by Dr. James. It has a very powerful beneficial effect on glycemic control with obesity and diabetic patients. As already discussed, Stampede trial is the one which randomized patients to intensive medical therapy, Roux-en-Y gastric bypass and sleeve gastrectomy, and the patients were followed for over 5 years. And it was found that all those patients who were in bariatric surgery groups had a significant, massive and significant profound weight loss and reduction A1C by 3%. So, that was the presentation. They are talking about the take-home messages. Weight loss is crucial in the management of diabetes. Substantial weight loss can lead to diabetes remission, and GLP-1 receptor agonists, SGLT2 inhibitors are the most effective drugs targeting both diabetes and obesity. Metabolic surgery can significantly improve glycemia with possible remission of type 2 diabetes mellitus. Thank you.
Good evening, everyone, once again. It is rightly said, to accomplish great things, we must not only act, but also dream. Not only plan, but also believe. May I now take the pleasure to invite the esteemed panelists. Before that, I would request Dr. Ravi Muppidi sir to take the bouquet and receive it from your best friend, Dr. Ashish Chauhan. Please come on to the stage, sir.
I must say, look, to hand over the bouquet to Ravi, Dr. Ashish alone is not enough. Can I call both the past president of IMA? I will ask Dr. Madan Mohan to call them out.
Dr. M.V. Rangarao, sir.
Rangarao, sir, please join us on the stage.
Dr. Ratnakar, Dr. Satyanarayana.
Dr. Satyanarayana.
Please.
And can we have all the speakers along with the chief, speaker, Dr. James Zakaria, to join us?
All speakers, please join the stage.
And definitely one person with whom Dr. Ravi cannot live without, Dr. Mrs. Ravi, to join us on the stage as we do the needful.
Dr. Mr. and Mrs. Ravi.
Yes. Please come. Can we have Dr. Satyanarayana and the past presidents of IMA and all the dignitaries? Please join us.
Let's give him a warm welcome with claps. You are the perfect example of dedication in the medical field. With more than 20 years of experience, he is an inspiration for thousands of his patients who have benefited for their thyroid, diabetes and other hormonal health problems, especially obesity. Thank you, sir, and thank you all the esteemed guests to come here and grace the occasion. Thank you so much.
Dr. Ratnakar. Dr. Rangarao sir. आइए 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 एक बार 2 मिनट के लिए आइए.
Can we have Dr. Mrs. Ravi please joining us on the stage? And to honor her, can we request Dr. Sujya to do the needful, please? Come please, ma'am. Ma'am, you got to be next to Ravi. There's no other choice. The first lady has to be with the president only.
Doctor, I request Dr. Ratnakar to hand over bouquet to the...
Yes, yes. Dr. Ratnakar sir, over to you.
Kindly hand over bouquet to the Dr. Ravi sir.
Dr. Sujya.
Dr. Satyanarayana.
Dr. Satyanarayana sir, to please join us on the stage.
He is here.
He is here only, okay.
Yeah.
And to the chief speaker.
Yeah. Dr. Satyanarayana sir, to hand over the bouquet to the Mrs. Ravi sir. If joined all speakers, one...
No. To Sarji, everybody standing there has to have a bouquet in the hand.
Yeah.
Can I request Dr. Madan to make sure that our chief speaker, Dr. James, has a bouquet in the hand? None other than Dr. Madan to hand over the same. Sir. Yeah. Anybody else?
Thank you so much.
You want to hand over?
And this is a graceful moment. I would like everyone to clap your hands once again and thank you so much.
Follow the speaker on the stage.
Kindly speakers on the stage.
I would like to invite the speakers on the stage as well. I would like to hand over the bouquet to Dr. Ashish Chauhan as well. Sir.
Yeah.
Really?
Yeah.
Okay. Is somebody clicking the picture or not? That's important.
Yeah. Sorry.
Thank you. Thank you. Can I have all the speakers, please? Rajita and Liz to join us, please?
For photo session, please join. Yeah, madam, please. I welcome the newly joined members in IIM Kukatpalli. Please come to the stage so that I will introduce you. Yeah, please. IIM members. New members that recently we have. Doctor? Dr. Elizabeth. Dr. Uzma Khan. Dr. Sumedha. Yeah, she's our anchor. Dr. Rashmi. Whether he is there? One more Dr. Musi. Oh, yeah. Dr. Musi. Yeah. Yeah. First of all, I like to vote of thanks. I will like to say that first of all, I am very much thankful for today's our speakers, all speakers, Dr. Ujma Khan, Dr. Elizabeth, Dr. Rajita, Dr. James, and I will thankful to the AED hospital and Dr. Ravi sir. Is an excellent CME. After long gap, we are seeing this much of audience. Today we have many new attendees. So some of them I have mentioned. I am taking the names. Thanks for attending this CME. On behalf of IMA Kukatpalli, thanks AED Hospital, Dr. Ravi sir and Dr. all team, and Dr. Ashish Chavan is there. He is all the way is coming from the Banjara Hills. Is attending this. Dr. Srinivas sir, Dr. Mallikarjuna Rao, Dr. Prasad, Dr. Nivedita Madam, Dr. Balram, Dr. K.V. Reddy, Dr. Usharani, Dr. Krishna Rao. They recently came from the USA and attending, I think, 2-3 days before only they landed in this. Dr. Sarita Madam, Dr. Suvarnamala, Dr. Neeraj sir also, he was in, actually he is a director of this Rainbow Hospital in the Hydernagar Kukatpalli. He was also in USA. I think 2 days before only he is landed in Hyderabad. Dr. Amrita, Dr. Yasmin is there, Dr. Satyanarayana Murthy, Dr. Jayasri, Dr. K.P. Reddy, Dr. Valia sir is there, Dr. Ravi Kumar, Dr. Chitranshi, Anurag Chitranshi sir is there, Dr. Anand, Dr. Prem Sundar, Dr. Rajesh, Dr. LVK Raju, is Dr. Balasubramanyam, Dr. N.V. Rangarao, Dr. Ratnakar, Dr. Madhaya, Dr. Shashikant, Julie Srinivas sir is a senior oncologist. Yeah, Dr. Mallikarjuna Rao is there. Dr. Suresh is a busy practitioner, and Dr. Vanshi Mohan, Dr. Srinivas, Dr. Subbareddy sir is a senior cardiologist. Dr. Ravindranath. Many more members are there. I may be missed some names, but I will thank one and all for this today's attending CME. It's a grand success. And I think this is efforts of the Dr. Ravi sir. Yeah. Thanks for AED Hospital. Dr. Chandrasekhar Rao is a joined recently. ENT surgeon, is a senior surgeon. ENT surgeon. I will hand over mic to the Dr. Sumedha. She will you will give the vote of thanks from your hospital and ask them to join.
Thank you so much, sir. Another round of applause for Dr. Madan Mohan sir. Thank you so much. Before concluding the session, I would like to go through the slide for the journey treaded by AED Hospital right from 2010. Slides, please. The journey strengthened day by day by improving quality and gaining patients' confidence. As a result, in 2021, AED Hospital was awarded Best Endocrine Center by Asian Awards Association. In 2010, backed up with the pharmacy, lab and OPD, a day was there when only 3 employees were there in AED Hospital, and with excellence of work and dedication, next year in 2011, diabetes was treated with 2 insulin pumps in hand. A single-man show, Dr. Ravi Kemupiddi sir got his training from USA to diagnose thyroid carcinoma and parathyroid adenomas, and in 2012 started with ultrasonography, Doppler, thyroscan and ultrasonography guided fine needle aspiration cytology. In 2013, yet another milestone was awaited. Inpatient facilities, operation theatre became functional. Fully automated hormonal labs with Roche E411 and Siemens in 2014 made AED Hospital achieve new heights. Electronic medical records were introduced further, making the hospital fully technologically advanced institute. Well begun is half done. goes the saying. In 2015, RSSDI accredited certificate course was started in diabetology for MBBS and MD doctors. It was in 2016 that a new floor in hospital was set up for complete diabetic care, addressing all diabetic complications. Yet another big advancement was made with the establishment of eye and dental care under one roof. Yes, ophthalmologists and dentists were recruited in 2017. Presently, Dr. Geeta Priya is attending the diabetic retinopathy patients. 2D Eco and Intensive Diabetic Care Unit was next in the pipeline. Total 30 employees were now working as dedicated hospital staff as per monthly payroll. In 2019, yes, AAD Hospital took a new turn with shifting to the new premises with better infrastructure, better hormonal lab, especially when dealing with COVID pandemic in 2020. Online consultation was also introduced. Now, last 2 years, 2021 and 2022, added icing on the cake with introduction of laparoscopic surgeries facilities, OT intensive care unit being fully operational. In 2022, new equipments were installed to begin with bariatric surgeries in a quest to find solutions to all the endocrinological disorders. Thank you so much for the listening. I would like to conclude the session here. The dinner is served. I hope you enjoy it. Thank you so much, doctors, once again.